Great. Thank you so much, Dylan. So it's especially a pleasure to be here. Paul probably does not recall, but he had a conversation with me when I was a medical student trying to figure out what I was going to do career-wise, and it totally changed my plans in terms of what I want to do. So it's particularly thrilling to be here, at a forum that's named after him. So I'm going to talk a little bit about opportunities and barriers to innovation and technology after the ACA and health delivery systems. So one of the multiple hats that I happen to wear here at UCLA is that I'm the director for UCLA's Connected Health program, which basically is trying to move our delivery system into adopting some of these new technologies, as well as also in the mobile health space. So I also happen to chair our IT's Mobile Health Advisory Committee. So in terms of thinking about innovation and technology, I think most people, at least I think most people in this room, probably remember going to the bank and actually changing dollar bills like this with the cashier. And that's not what we do anymore. We all go to ATMs. I mean, occasionally we'll go inside the bank, but we're very comfortable in terms of doing all of our transactions without having to see a person face to face. And then, of course, these days, people are probably using different type of apps, whether it's Apple Pay, Samsung Pay, Android Pay, to actually just wave your phone in front of a card reader so that you can actually get your transactions done. And I think that similarly, as we think about what we are looking at in medicine, I think most people can probably remember this particular picture in terms of how we would normally think about providing healthcare, having a face-to-face encounter with the doctor where they would do a physical examination. This is an example here of what we do in telestroke with some of our providers, where we are actually providing consultation services into outlying emergency rooms to make a decision whether or not we're going to provide clot-busting medications for somebody who's coming in for a stroke, which we'll do rapidly since we need to do it within a certain time window in order to preserve brain function. And then, of course, looking at individuals over a screen like this is something that we've actually been doing for quite some time, which I'll talk about a little bit more as well. But I think that increasingly we are looking towards mobile solutions because, again, that is where all patients are really at. Most people have smartphones, and we need to think increasingly about how we actually work in a patient-centered way to deliver care where patients are at. So sort of following along those lines is where the footprint is for UCLA Health. So I think that most people here who may have remembered UCLA Care, for example, when I got here in 2005 as a faculty member, we pretty much were just based here at Westwood, just across the street in CHS. That's where the hospital was. We had some clinics. We had a few outlying clinics. We had more, but they got reduced, during the first wave of managed care. And then we had Santa Monica as well as a hospital that we were also working with. But increasingly, we've moved out all across the west side of Los Angeles, up into the San Fernando Valley, out past downtown. We've gone past South Bay, actually down into Orange County. And as we think about these patients, while we do have clinics out here where people can actually see us, that doesn't give them the broad array of specialists that, for example, we might have at our institution globally. And so patients out here will physically drive to come out to Westwood. And even if you were just over the hill in San Fernando Valley, that 5-mile drive could be an hour in traffic, depends on when you're coming. And then, of course, you're going to try to park in Westwood. That's going to be $12, $15. Then you've got to wait for your doctor. That might be a half hour if it's my clinic, which chronically runs late. And so at the end of the day, that's not helping the patient in terms of what they really want to get. And so in order to actually provide care that patients want, we need to think about other type of delivery models. So I'm going to talk a little bit about video visits as one option, and then another option being remote patient monitoring. And so in terms of video visits, this is a technology that's actually been around for quite some time. So telemedicine is not new. We've had the technology to do this, but the technology was much more expensive even up to about 5-10 years ago. So we do have some of these $10,000 camera equipment and video screens to see patients really well, but quite honestly, a lot of the things that we can do, for example, with teledermatology, can be done with the HD camera that's on your smartphone. It has good enough resolution to provide most of the things that we would need. So, and increasingly, some of our colleagues, in the School of Engineering are coming up with plug-in devices that can actually see things down at the molecular level. So even though something like Theranos did not work out very well, those type of technologies are probably on the horizon. That being said, we have a big problem in terms of moving out video visits, in terms of offering it much more widely. Now, on one hand, we're very lucky to be here in California where we actually have parity in terms of telemedicine. So A video visit encounter will basically be paid the same way as a face-to-face visit by most insurers, with the exception of Medicare. And so in terms of thinking about a post-ACA world, there are some things that the ACA was able to change, but there are other types of regulations that haven't been changed. And so, for example, for telemedicine for Medicare, we essentially have to do a visit with a patient. They have to be in a clinic rather than at their home, and they need to be in a rural designated area, and there are only 5 rural designated areas in Los Angeles County, and I'll give a prize to anybody who can think of the 5 that are out there. But they're not close by. So in terms of thinking about the barriers to us actually rolling out this type of innovation that, again, has been around for a long time but is now widely accessible, and again, given that many people who are underserved also have smartphones, we could deliver this kind of care, but we actually have some structural barriers in terms of providing this kind of care delivery. That being said, the other thing about video visits is that when we are in situations where we actually have global payments, we find that providers are actually much more willing to adopt these kind of technologies, and that, again, sort of presages as we think about affordable, accountable care organizations and doing more population health. As we look for ways that are going to provide care efficiently, this is going to be one of those ways. The other thing is remote patient monitoring, and so this is just an example here of our UCLA Health app, and then this is just an example of a way that we could potentially do remote patient monitoring out of one of the studies that I led. But the thing is that now that we've got these technologies that are basically smartphones, we have a wide array of sensors that are at our fingertips that we can actually use to get information about patients wherever they're at. We don't need them to come necessarily into clinic to, for example, get blood pressure measurements, even listen to their hearts over a stethoscope, get blood glucose measurements or other types of things. We can actually have plugins or Bluetooth-enabled devices that can then beam that information back to us, and potentially securely, although that's still a big issue that we still need to work out, to give us that information so that we can manage patients more appropriately. So as we think about population health and how we want to manage those individuals, we want to get information from people wherever they're at. And so these kind of technologies are things that we want to look towards, and we're looking at ways of bringing this kind of information to our health system. Again, in terms of how reimbursement works out, if we're looking at a typical reimbursement strategy in terms of doing chronic health management, we get paid $40 a month in terms of doing this kind of remote patient management. That's probably enough to pay for the phone line, nothing else. So, in terms of actually coming up with a way that we can manage populations, we would need to be in a different reimbursement structure to really adopt these technologies broadly. So I think with that, I'll stop here, and happy to answer more things as we go on in the conversation.